again, so we can go ahead and get started.
Okay, thanks, Katie. Welcome, committee members of the Finance and Revenue Committee, to our supplemental February meeting. We're still doing 2 meetings a month, and I think they've been scheduled probably through June or so. So I'd like to welcome everybody, and we'll start with roll call and agenda review. So Katie, can I pass it back to you?
Yes, absolutely. So when I call your name, just please let me know that you are here. Cheryl Ramirez.
Here.
Chunwei Chi.
Here.
Chris Hogan. Richard Gibson. Jeff Goodman.
Here.
John Santa.
Here.
Bethany Stairs. Charlie Swanson.
Here.
Wonderful. Thank you. So we have Cheryl, Chunwei, Jeff, John, and Charlie with us so far.
Thanks, Katie. Oh, go ahead.
Sorry, I'm having some issues with my computer. I'm gonna it's not letting me advance the screen. So just give me 1 second.
Okay. And it looks like Richard's here now too.
Oh, perfect.
So could I make just a couple of announcements really quick?
Yes, please do.
Okay. So the first announcement is that Samantha DuPont has stepped down from the committee, just due to a lot of competing demands. Totally understand. I don't believe we need to fill her spot because the committee's, when we did the recruitment, you know, we just had a certain number on the committees, but it wasn't a prescribed number. So I would defer to staff whether we need to recruit for another position or not, but I don't think so.
Cheryl, I will take a look at the policies and procedures. I do not think that you need to, but I will double check and let you know.
Okay, thank you. And my other announcement is actually a question, and that is the operations committee chair invited our committee chair, the other committee chairs, to give him any questions on waivers that we have, since they are kind of digging into waivers in the operations committee this month. So if you do have questions that I can share with the operations committee chair, just send them my way via email, or if we have time to just talk about them at the end of the meeting, we can do that too. We'll see. Okay, so with that, we did roll call. All right, so today's agenda, we always give a summary of feedback from the previous meeting to make sure we're all on the same page and have the same perspective on what we had talked about previously. We're going to review health expenditures as well, a straw proposal that Charlie has drafted and you should have received in your email. We'll continue with the health expenditure discussion. That's also led by Charlie. We will next go into research questions that the committee feels that we need to have answered. We want to make sure we have consensus from the whole committee on what these research questions are. And we'll do a little update on the research questions that have been asked already. And then we'll go into resource needs for Finance and Revenue Committee. That will be mostly led by Jenny. And at that time, let's see, I think we'll probably do an update on the RFP process, which makes a lot of sense in that time. And then we'll do, as usual, reflections, recap the meeting, talk about next steps, next agenda review. As you can see, we're not talking about revenue today, except for, you know, maybe research questions and resource needs, but this is really about health expenditures today. And then I believe there's no public comment today at this point. So as you can see, we're still working on health expenditures. We're going into our 4th month on health expenditures. My personal goal is to be done by the end of March. Let's see if we can make it. And we'll be working on revenue at the next meeting. So here's the Here's the flow, so just to remind you. Okay, so the feedback that we received last meeting, of course, we talked about various taxes. It seemed from the comments that we wouldn't talk about a statewide property tax because it would require a constitutional amendment and needs significant public input. If you see that differently, of course, let us know. Same with the sales tax, didn't think there would be appetite for a sales tax. And we agreed that the administrative cost savings estimates were very low from the Rand report and the Optimist analysis, and that we'd like to spend more time on this topic. So we will be doing that. Anything else? Oh, go ahead, Richard.
Yeah, I mean, perhaps most people don't feel that a sales tax is workable, but I just don't think we're gonna make it without considering it. I think the income taxes and the payroll taxes are gonna be so high as to make them unworkable since we're starting in a place that they're already so high. So anyway, we're not making a decision here. I got that. I just think I believe we're gonna have to at least consider it and look at the numbers. And I think we're gonna need to do citizen interviews because when they find out 15 or 18% income tax, I just don't think that's a starter either. So just my point of view. Thank you.
I tend to agree with you, Richard, and I thought the same one, with the task force. So let's not take it off the table then.
Okay,
Let's
thank
talk
you.
about it some more. Yeah. Okay, any other comments before we move on? Okay. Let's go to the next slide. Okay, so we're going to move on to health expenditures draft proposal. As you may recall at the last meeting, I mentioned that the board is asking for a straw proposal from us. There's a certain format that they require, and Charlie kindly drafted one for us. So the way that we're going to work on this is Charlie can review, and I've been told by Katie that she could do real-time edits as we're moving through this if we have edits. And my understanding is that we can make any final changes to the straw proposal by the 12th of February, so about a week. And then it goes to the board on the 13th. It has to be posted a week before the board meeting, so that would be the 12th has to be final. Now, with the public meeting laws, this means that if you do have changes, you'd have to send those to staff. And we can't go back and forth on email about these changes. So you would just send them directly to staff and they would make those corrections. So I'm kind of hoping that we can just get it all done today. And any other changes would be really more like typos and stuff like that, and not substantial changes. So that's my hope. So go ahead, Charlie. I'll hand it to you.
Well, I'm hoping people had a chance to read it. The essence is pretty much what we've talked about for quite a while now, and that is we're basing the overall outline of the health expenditures on the national health expenditure accounts, and then trying to get Oregon-specific data to flesh out what those expenditures have been in 2023. That's really the key. We're gonna keep around some data for previous years, so we have some trend data as well, and which we may need as we're going to try to at some point project into the future. So I would say that to a large extent, this proposal is really saying we have a spreadsheet that we're working on that provides this data. And I've sent that in as well, the spreadsheet, and it's, and we'll talk a little bit more about what's missing or what is not so well determined at this point. And it's not clear whether we'll be able to determine more on some of these issues, but we'll try. So I guess that's kind of the essence of the focus of the recommendation. There's quite a bit of data in there from many other sources besides national health expenditure accounts, which we've already talked about, only go through 2020 for Oregon specific data, but the NBS data is up to date, well, up to 2023 for Medicaid in great detail provided by OHA. And there's good data from a cost growth target on expenditures, especially in Medicare, which allowed estimates of what comes from out of pocket for along with Medicare, I guess. So anyway, that's the essence of the focus recommendation.
So before we open it up for questions or comments, I would just start with my own. I think I would suggest in the high level summary that we actually frame this in the form of a recommendation so the board is really clear on what we're recommending. That's my comment.
So I'm not quite sure how that is different than what's there, but
Well, what are we wanting the board to approve? The fact
I
that
have no idea. I really have no idea why the board is thinking about whether they need to approve data. I mean, it's like, okay.
So I suppose what it is though, is it's a recommendation on this approach and on using this particular data. Now, I had mentioned this already at a board meeting, but they did specifically ask for a straw proposal this time. So I'm just wondering if we should be just really clear that we're using this approach and this data and this framework to get to the total health expenditures, something along those lines. I don't have the exact wording, but I can work on that.
Yeah, that would be great because I'm not quite sure how to word something of that nature,
Right.
but
Yeah.
hopefully you can figure out. So
Yeah, I'll do that.
Well, the high level summary says it, estimate of the 2023 Oregon healthcare expenditures categorized by sources one. And this is round one. So this isn't the final. It's just that as we go over the next few months, as we work on the revenue, we continue to refine the expenditures to get them and also take in plan benefit design. They're all pointing to a single common point in the future. But this is a recommendation, one, of the high level summary, and two, that an acknowledgement that this is the first round of this and we'll continue to refine it.
Yeah, I want to make sure it's really clear when they're asking for a straw proposal that it's actually a proposal or recommendation. So I think we can frame it in that way.
Okay.
Yeah.
okay, thanks.
So anybody else have questions, thoughts, feedback? Chenwei.
I just have a quick clarifying question on the private health insurance part. Does that include the self-insured corporation?
Yes, I mean, to the extent that we can estimate numbers for it, yes.
Thank you.
But again, that's really hard data to get at. So they are definitely just estimates. But there's a number of ways we're checking on it to try to make sure that it makes sense.
Thank you.
John.
Yeah, Charlie, I mean, wow, what a lot of work to do. But like the previous commenter, I think it would be good if you made clear somewhere the term, self-insured employers were used, and a statement was made that the estimates were made, and the reliability of those estimates was significant. Because I think that was, as I recall from our earlier discussions, the single toughest issue, and it sounds like it remains the same.
Yeah, I would say maybe out of pocket might even be a tougher issue. They're both hard because the data is not that good. But so I'm not quite sure how to how to say that, but the estimates kind of start from, on both those cases, start from extrapolating or the national data that goes up through 2020 to 2023 and checking it with kind of leftovers. So there's actually good data available for 2023 and other years on the commercial side of private insurance, that is, those that are not self-insured. And so the leftover is from the projections is used to say, well, this is plausible. And that's about the extent that I would say we can do. And it's hard to, I have made some estimates, but I haven't included them in the spreadsheet yet of what the uncertainties are in some of these areas. And I'm going to try to do more of that, but that's not complete yet. So.
And I think just maybe adding a comment like that somewhere in here saying that these are the areas that are most difficult to estimate.
Okay, that would make sense.
Maybe after the sentence that ends in small group insurance, if you're going to say something specifically about self-insured estimates.
So let me just check and make sure. I'm trying to, it's pretty small on my screen trying to read it, but maybe I can get it bigger. Here we go.
Yeah, the sentence complete detailed recent data exists, and then they're all mentioned, but self-insured is not specifically mentioned.
Okay. So we could say something about self-insured is estimated from extrapolations of earlier year data from national health expenditure counts, and the validity of that is checked, or the plausibility of that is checked against the leftovers. And I can't think of words right now on the fly.
Could you put in a placeholder there right after the small group insurance, just so we can remind ourselves to craft a sentence or two about that?
Yes, definitely.
Okay.
And then I did see that Janine had her hand up.
Janine?
I just wanted to remind folks that the cost growth trend data include the self-insured about, I think it was estimated somewhere in the 60% range. So we should look at that as since it's not so clear in the NHGA data as it is explicitly called out in the cost growth trend data.
Yeah, so when I looked at the cost growth data and compared it, it seemed like it could be as little as 45% of it was included. That's kind of where my numbers came out, but it could be that it's more. And so again, that's where a big uncertainty comes in. It's not clear exactly how much is included and whether the unincluded parts would be similar. So
But they have known reporters, you know that at least that, whatever it is, 40–60%, somewhere in there is at least partially in there, because they have a list of those voluntary reporter or mandatory, both mandatory and voluntary reporters there.
Yeah.
Janine, do you have any suggestions on how we would include that information in this recommendation, or are you suggesting we include that information, or is that just for us to know?
Well, one, it's us to know. Two is, I think you could say that, that's part of the areas that will be included is, so you've got complete blah, blah, blah for commercial individual insurance, small group insurance, self-insured, something like that could be put in there. At least you've considered it. And I agree with you, Cheryl, it needs to be a more formal recommendation. It should say, we propose to use an estimate of 2023 expenditures based on the following data sources and extrapolated to 2030.
Yeah, that's a really good, thank you for writing that recommendation for me. Yeah, that's exactly what I was
Yeah, it just
Where I
needs to
wanted
be,
to go.
instead of high level summary, it should be the actual thing that they're gonna vote on.
Right,
That's
yeah.
what the board's gonna be looking for.
yeah. I agree. Thank you, Janine. Any other comments about this straw proposal?
I mean, should we go further down? I'm not sure if we need to go to other portions of it.
Yeah, we should. Let's go through the whole
yeah.
thing. See if there are any other comments.
Okay. So I guess at this point, the recommendation is we're not trying to say much about 2030. We're just trying to say something about 2023. And in the future, we'll make some attempts for 2030, but not quite sure if that is
Right.
sufficient there, but
Yeah, I think the way Janine phrased it sounds good, that's the assumption that we're using 2030, or we're extrapolating the right word to 2030? I don't know if that's the right word.
projecting.
Projecting, yeah.
Yeah. I mean, we aren't doing that yet. I mean, this is not part of the proposal at this
Right,
point,
yeah.
but we intend to.
Well, and it's possible they may not agree with 2030, I don't know.
Right.
So it's
I mean,
worth-
that's sort of up to them to choose, I
that
guess, at some point,
it's
but that's what we would suggest.
yeah, it's worth putting in the recommendation, I think, just to be as specific as possible. Again, I've mentioned this in my report, that this is more formal. Anybody have any other comments on these other questions? John?
Yeah, Charlie, there's no discussion that I saw. I may have missed it about. So how does this stack up to what Optimus did? And I assume that's also something that can be done in the future. When it's trued up to whatever year we choose. But I mean, I'm hoping at some point our effort generates kind of a calculator that the folks who succeed us will be able to more easily come on to and say, well, here's what the key assumptions of the previous folks were, and which do we agree with and not, something of that sort. Any comments about that?
Well, so I can make an attempt to, I guess, fairly quickly compare numbers to Optimus. Optimus was pretty much 2020 or 2019 and 2026. And I do have 2019 data in most, I think in pretty much all of the estimates, and I can compare that to what Optimus said. But I haven't written it out as part of the proposal, but I certainly could try to do that in the time frame, but we wouldn't have a chance to review that at a meeting, apparently. So, I could try to do something and send something to Cheryl, I guess, but
How about for round two? Just do that. We'll do that for a month from now for round two of this.
Yeah, I'm not suggesting that it needs
yeah,
to be there. It's nice to hear that
okay.
that it's looks like it's doable, and I don't think it needs to be a part of this, but I think it would be good for all of us and then for going forward.
Okay, I mean, that sounds reasonable to me, so.
Yeah, me too. Thank you. Any other comments?
I think I don't see in there anything that says exactly why you picked 2023 explicitly. I assume you could say it when you're presenting this, but it's because of post-pandemic, etc.
Oh, yeah, good point.
So like if someone wanted to question you guys, why 2023? I don't
okay.
see points in here that suggest why you picked that.
So I guess briefly say why it's the most recent year for which data
Is it
exists.
Mhm.
And also what the comments you made about it's seemingly far enough away from it's post-pandemic enough that we think things we think things are settled in. I mean, I guess I have no idea about the pandemic other than that but the other piece that we need to keep in mind is we want to have data for a number of years. And so the attempt has been in all of this to at least include 2019 through 2023. And so, maybe that should be explicitly stated as, yes, we're focusing on 2023, but data is collected for a range of years so that things can be compared and looked at and projected eventually. So I'm not sure how much we need to say about that, but maybe we do.
I think maybe just a sentence or two of explanation is just fine. Any other comments or additions? Okay. So the way forward here is, what I heard is Charlie's going to draft a few sentences about the things that we mentioned on self-insured, why we chose 2030 and no, why we chose 2023. And let's see what else. The fact that the cost growth trend data includes self-insured estimates. We've got a draft recommendation that Janine offered, so I can help with that. So I would say, rather than trying to group edit here, if you're willing, Charlie, to make those additions, I'm happy to take a last review and add the recommendation so we can send it in.
Yeah, so I will work on the explicitly why 2023, and I'll probably put in something about we're actually trying to keep a range of years, and then something specifically about self-insured. And I guess you will work on the making it more of a recommendation sort of
Yes,
thing.
I'll do that.
Oh, Okay, thanks.
And I'm hoping that none of that is controversial and that we would need to bring it back to the committee, because then we're going to miss the deadline for the next board meeting. So I'd rather just get it in. And as you all said, there will be a second straw proposal that will go into more detail comparing this health expenditures estimate to the Optimus anyway. So we can add more details into that next one too. And it depends what kind of feedback we get from the board too. So there's that. Okay, that sounds like a good plan. Any other concerns or comments? Chunwei?
Yes, and again, I just want to bring a cautionary note that the self-insured expenditure is quite substantial. So in the future, when we try to find any estimate, keep in mind, because I just came across a 2021 report to the Congress that of all the group insured that has 100 or more people, in that year, fully insured plan only account for 13 billion. Self-insured plan account for 60 billion. And then there's one category more complicated called mixed insured. So the mixed insured are corporations who have partial self-insured, partial purchasing health insurance. So that's the largest, 75 billion. So this will be tricky to try to catch the relative or approximately accurate estimate.
Oh no, another complication. I've not even heard of that yet before with mixed insurance. I didn't know that was a thing. How do we deal with that? Do we?
And the mixed insurance, I think, is where companies, it's not individuals have mixed insurance. Well, they might too, but it's more that a company has some of their employees that they self-insure and some that they buy insurance for. I mean, for example, Oregon PEB has both fully insured and self-insured portions of it. And so, yeah, that exists throughout large industries and lots of public entities as well.
Okay. Well, thanks for clarifying. Anything else on this before we move on to the next thing? Okay, so we have a plan and you all are okay with delegating Charlie and myself to wrap this up and send it in? Yes. Okay, all right, great. Okay, so we're gonna move on to healthcare expenditures work, and that will also be led by Charlie. You may have seen spreadsheets and his slides already, so hopefully you'll have some feedback, and thank you so much for all of this extra work, Charlie, in between. So I'll leave it to you.
Okay, so we can go to the next slide, and I'm just going to, I probably won't go into too much detail here, just kind of pointing out that from my analysis, I'm relatively comfortable with the things that are in green, which means I am relatively comfortable with the private health insurance numbers, although there's lots of uncertainty still, but and Medicare and Medicaid and CHIP. I think that the Medicare, Medicaid, and CHIP I'm pretty comfortable with, and the private health insurance I'm as comfortable as I think I'm going to be able to get with the data that's available. But I will look a little bit more at how this compares with Optimus to just check up on that. So the yellow numbers are ones that I still think we need to, they are still just there from imputing from national data at this point. So I haven't done a careful enough look to get what I think are better numbers than just Oregon's fraction of the national population, I guess. But that's kind of what I'm working on at this point. What I said is the unlikelies, those are things that I expect the governance board plan will recommend not including. There's a few other things that they might decide to not include, but I'm expecting that the out of pocket for other non-durables, which is basically over-the-counter purchases of a whole variety of things that is almost all out of pocket now nationally, I would expect that is mostly not going to be covered. There might be some people on Medicaid for whom it's covered, but in general, it probably wouldn't be by the plan. I would expect the Department of Veterans Affairs will be not included. I mean, the people who are eligible for those benefits would be included in the Oregon plan, but the taking it over is probably not going to happen. It probably would not be allowed by the federal government anyway. So we can go to the next slide. And so the other unlikely things I would say are the Indian Health Services and research that would probably not be covered by the plan. And you can see on this slide where most of the things that have not yet been carefully explored exist. So all of the yellow square are blocks, but they are, for the most part, not that big of a category. So the largest, well, actually, I think I'll go to the next slide after this, and if you can see, I think I have oh no, so this is different. We'll go on. We'll find out more about what are the largest unexplored categories a little bit later, but I think I still want to go to the Medicare slide at this point. So this is the details for Medicare expenditures, and I've made a lot of use of the cost growth target data to try to estimate what comes out of pocket. The way my understanding is the way the cost growth target data is put together, that a Medicare claim is called Medicare, even if some of it is paid out of pocket. And so putting together other sources with the cost growth target data, I've made an attempt to estimate what out of pocket goes along with typical Medicare expenditures. And that's the bottom 5 rows there are the estimates from out of pocket. And so I've also tried to put in what's actually paid by Medicare itself, that by CMS, what's paid by private insurance. So that is, and again, private insurance, the Medicare Advantage is private insurance, but most of what Medicare Advantage pays out is paid by Medicare. So it's paid by the federal government. But there is some private insurance portion that comes from the premiums paid by individuals, both for Medigap and for Medicare Advantage. And so that's what that from private insurance portion is trying to look at, is what's actually coming through private insurers for Medicare patients, and then the out-of-pocket down there. So, and the reason for splitting it out like this is because the private insurance portion and the out-of-pocket portion are things we probably need to try to recoup in new taxes or in savings somehow. And the part by Medicare, we're hoping that we can get continued payments from that. So we wouldn't have to have new taxes for that if things work out well for us. You can go to the next slide. So this is, I think somebody brought up, how is Medicare funded anyway? And so this is just a list of the places where Medicare funding comes from. And so payroll taxes do a little bit more than a third of it. The general fund pays for more than that. About more than 2/5 of all of Medicare is covered from the general fund of the federal government. And that's primarily the payroll tax is almost solely used for the hospital portion of it, Part A, basically. And the general fund is used for both Part B, C, and D, but there is a large part of Part C, the Medicare Advantage, that comes from the payroll tax as well because of the hospital portion. You can see that there's premiums cover a part of it. The biggest premiums are those for Part D. And there's some from Part B, and Part D there's some, and also there's some people that would not qualify for Medicare except for by paying Part A premiums, and so there's a little bit of that going in too. There's also state transfers to Medicare, and those are primarily related to Medicaid dual patients, that the state Medicaid money that comes both from the state and the federal government goes into the Medicare funds. And there's also a tax on Social Security benefits for the purpose of funding Medicare. So this is sort of a breakdown of that. You get an idea of where the Medicare funds come from. Okay, next slide. So this is a listing kind of where does the data come from. So a lot of the commercial portion comes from premium loss reports for organ insurers, and this covers essentially all individual policies, almost all small group, quite a bit of large group, and ATM, which is Associations, Trusts, and MEWAs, and then over 50% of Medicare Advantage. So the values are extrapolated then to get all Oregon enrollees from DCBS quarterly enrollment reports. The Medigap details are from the National Association of Insurance Commissioners, for which there's Oregon-specific data, but only a fraction of the enrollment, Oregon enrollment is covered by that. But then I extrapolate to the else. I also do imputing from national values, which are provided by another website. The cost growth target data is available for Medicare Advantage and Medicare fee-for-service, and that's used to check on the other stuff and also to try to estimate what comes from out of pocket for those claims. And this relates to the self-insured question. The leftover amount in private insurance is attributed to self-insured. So the 2019 and 2020 data exists for national health expenditure accounts, Oregon-specific data. And if I use all those sources that I just described, the leftover amount says that the self-insured per life covered is essentially at the same value as commercial large group insurance. And that makes sense to me. I'm not sure if it's exactly right, but it makes sense. And then the other piece that I can find from that is the overhead for self-insured is apparently about 8%, which is, and it's about 14% for fully insured commercial. And again, this also makes sense to me, but it's again more of a plausibility argument than it is a yes, this data is correct argument. And then this is what I mentioned earlier, that the leftover amount compared to the cost growth target data looks like somewhere between 42 and 48% of the self-insured is covered by the cost growth target data. If it is actually up to 60%, then the self-insured are a smaller group, a smaller amount of money than what it looks like from the other data sources I get. So that this is sort of a discussion of how I'm getting some of that information and some of those estimates. And then we can go to the next slide. So the among the next tasks is trying to say, well, where does this money come from for all these categories? You know, how much comes from the federal government? How much comes from state government? How much comes from local government? How much comes from private insurance? And how much comes from out of pocket? So a lot of that exists for these as well. And I've pretty much already got a lot of that data, but I have not gone through and categorized it in the way that I want to yet. So I will be working on that. And again, quite a bit of this can be done accurately, and some will require just estimates. So we can go to the next slide. So these are the biggest remaining categories that are out there, and the numbers that I provide are imputed from national data. So they're I don't know if they're reasonable for Oregon, but that's what Oregon's fraction of the population suggests how big they are. So I think a really important one and a very difficult one is going to be expenditures on its structures and equipment. To me, it's going to be really important to have an idea of that for equity purposes. You know, looking at what the task force recommended, I'm expecting that that would be included as a likely part of what the governance board would want to do. Another big category of almost 2 billion or about 2 billion is expenditures of public health. And again, that may or may not be necessary, but I would expect there might be some coordination between personal public health that's going to be useful. And so understanding those expenditures could be useful for the governance board. The next group, about 2/3 of $1 billion, it looks like it is spent on workers' comp. There is some pretty good Oregon data for 2017 and good estimates, I think, about the medical portion of workers' comp. And there's also detailed data for total workers' comp that exists through 2023, or at least through 2022. I'm not sure about 2023. And but it's hard to tease out what part of that goes to medical care. And it's also not clear how that would be included in what the governance board might want to do. So, you know, would those expenditures still continue to go through workers' comp, or would the plan take over the medical portion of workers' comp, or would there be some just coordination between the two? And to me, it would be useful at some point to have a conversation with people who understand what's going on, at least with SAFE, the public entity that deals with workers' comp, to find out, well, how do they think it could work? Because I think it's both a finance and revenue question and it's actually three kinds of questions: a finance and revenue question, an operations sort of question, and potentially a plan design and benefits question of how does the universal plan work with workers' comp? And it's a noticeable amount of money. I mean, it's not a huge amount, but maybe 600 million. It's probably a little bit less than that in Oregon, from what I can tell. My preliminary data would suggest it's probably more like 400 million, but so then another about $500 million roughly estimated thing is other state and local programs, and I'm not quite sure what those are yet. So I need to try to figure out what all those are, and if we can get data on that. There's also other federal programs, and there's school health. So those are all things that still need to be explored. Is there anything more? I think that might be it.
So that's a lot to unpack. Does anyone have questions for Charlie? I have one, I think, fairly simple question. In the Medicare out-of-pocket, does that include vision, dental, hearing? All those services that Medicare doesn't pay for?
I mean, so in the National Health Expenditure Count, the answer is yes. Whether we can get Oregon data on that, I don't know.
Okay.
But yes, the intent is that all of those things would be included, and we would try to figure out, we can do the best we can to estimate data for it. Yeah.
Okay, thanks, Charlie. Chenwei.
My question or comment is on the public health, expenditure on public health. This include, for example, the state funding budget for the Oregon Health Authority, as well as county funding for all county health department? And I assume, and we can bring this to the board meeting, that if we implemented the universal health plan, those public health agencies from state to county will still functional. And that means those public health function and their budget should not come from the universal health plan budget. They have a separate administrative budget.
Yeah, and that may be the way that is best to go, but I think it's useful for us to try to estimate those costs. And maybe we don't do anything more with it, and we just say, well, that's one of the costs that National Health Expenditure Account says is a part of total expenditures on health, and it's one of the reasons that other numbers that come up look small because they don't include that. So that's part of why I'm including it.
Thanks. I have that same thought with Chenwei. So any other comments or questions about what you've heard, seen? Before we get to next tasks, John.
So part of our intention about, excuse me, John, I talked to you, put your hand. Go ahead, John.
Charlie, I'm not sure I'm following your comment about equity as it relates to the equipment and buildings.
So many advocates, and I think even the task force would say that the siting of hospitals and the decisions about where new facilities should go and where new equipment should be placed is a societal question and not a private enterprise sort of question. And that it may be the case that the best way to deal with that is to not do the certificate of need kind of program that we have now, but to actually have funding coming from the universal payer in order to appropriately locate facilities or expand facilities. So I mean, that's an option that I expect that the governance board will be playing with, and is about how to best deal with that. From my standpoint, from an equity standpoint, I think it's very important that the governance board have a big say, or the state and society in general has a big say as to it, where new facilities go. And in order to do so, it'd be nice to know how much that typically entails.
Right. Okay. Okay. Thanks for clarifying that. Then just a comment about the workers' comp issues. To me, in many respects, I hope this is eventually perceived as it's a coordination of benefits issue. And right now, what happens when somebody comes in and they have back pain? If either they or the provider think that there's a chance it's job related, then the provider is required to file a form asserting that this may be covered under workers' compensation. And then usually the workers' compensation company investigates that and makes a decision about whether they believe it's related to work or not. And if it's related to work, then they pay for the medical expenses, but they also pay for the time lost. They pay for any disability. They pay for ongoing medical expenses related to it. So, that can be quite the significant decision. And that can be arguable, because obviously they have a incentive to, not decide it's work related. And there's a back and forth, I think, that happens between insurers and workers' comp companies about that. Same thing, by the way, for automobile insurance. That automobile insurance covers some of the medical costs of accidents. We just need to clarify. We had this discussion at the task force that combining medical and workers' comp is a challenge. That was looked at significantly in the 90s when there was a number of procedures to look at 24-hour, what was called 24-hour insurance. Actually, I worked for Blue Cross at the time, and I can remember many meetings with SAFE about the feasibility of doing that. And the decision eventually was, we're just two different companies with two different philosophies. And frankly, workers' compensation is more of an adversarial situation. And I mean, there's a whole court system for workers' comp law and coverage. And I think it's just fair, to me, it's fair for the finance committee to say at some point, okay, if you want to take this on, you can take this on board, but it's going to be, because I think, Charlie, that the if you add the non-medical expenses, it's $1 to $2 billion of expenses. And, that means you're going to replace the revenue. The other issue for us is, that is currently being funded 100% by employers, 100% by employers. And, they have a lot of ownership as a result over what happens to that money. And anyway, there's just a whole set of issues that are relevant to what we're doing and could have an impact on what we're doing that the board needs to be aware of.
I mean, I would just add that at this point, my attempt is just to document the expenditures. Yeah.
Very good points, John. I hadn't really thought about workers' comp too much. So in terms of making a decision on whether we're going to include workers' comp or not, what would we need to do? Talk to SAFE, as I think it said in one of the slides, or what would be a way to kind of figure that out before we drop that topic?
Well, this is John. I think you could talk to SAFE. I think it'd be a pretty short meeting.
Okay,
Yeah.
okay, Richard.
Oh, two things on the workman's comp. I think that we want, the main reason we're doing a single payer plan is to cover everyone equitably and to lower administrative costs. And I think still workman's comp would benefit by having a single payment plan with a single statewide rate. So that even if it came directly funded by insurers through a SAFE, directly funded by employers through a SAFE program, it still would save administrative expense to have them pay at a standard rate across all the hospitals. So I think there's still benefit, even if we don't include that in the taxation for the single payer plan, which I don't think we should do. Katie, could you go back to the slides that have the yellow rows? Next one. And yeah, this one. The reason why we wanted to use the spreadsheet is so that the governing board, maybe with recommendations from this committee, the governing board could go through each of those lines and say, what part of maternal child health is included in the single payer plan and what isn't? What part of vocational rehabilitation is included in the single payer and what isn't? So we're not trying to be directive at this point because it's not our call, but we want to line it out that here are all the numbers there. And you might say, well, once you're down into less than 0.5%, let it go. It's not worth the effort. And maybe that's the right approach. But we want, as Charlie said earlier, we want to put it there so people know where the money's going, so that one, they're aware what's in and what's out, and number two is just so we have a very complete rendering of everything that pays for care in Oregon. It's just good practice. Thank you.
Thanks, Richard. Chenwei?
I just have a quick comment. What we just discussing about workers' comp is a bigger, broader issue. I think need the governance board to discuss, because besides workers' comp, John also mentioned about auto insurance, and there's also property liability insurance. There are multiple type of insurance that include healthcare, and this needs a bigger discussion. One of the strategy, I'm just using Taiwan's national health insurance as an example. They deal with that early on and decided they are going to keep, they have a comparable workers' comp. It's called the occupational health and safety benefit. And so they keep those benefits as well as auto insurance, liability insurance intact without touching them. But instead, they implemented a procedure called subrogation, meaning when a medical bill was incurred that's attributed whether to occupational safety or attributed to auto insurance or attributed to other liability insurance, the government then asks those in charge of those insurance or agency to pay for those medical bills instead of having the national health insurance pay that. So this is an option that the governance board probably need a deeper discussion.
Thanks, Chenwei. Other comments before we get to
I
next?
could just make a comment, Cheryl.
Oh, go ahead.
I think maybe things have changed, but in my day when I practiced, one of the most frustrating things in the community was when you would see a patient, you would take care of them, you would do what you were supposed to do, you would submit a claim, and the claim would be suspended because of coordination of benefits. So you'd be sitting there sometimes for months or longer, waiting for these two insurance companies to decide. I think one advantage of a single payer would be we'll pay you, because we have your stability at stake. We'll let you know eventually how we did in terms of negotiating with this or that insurance. And I think a single payer could have a lot more clout. And I think this is what Chenwei was saying around subrogation.
Okay. Yeah,
Yes,
I wasn't sure what that word meant, Chenwei.
yes, that's what that's what Taiwan's National Health Insurance did. They have a single payer to pay all medical bill, but then when they identify this is due to auto accidents, then the government asks the auto insurance responsible to reimburse the government.
Thank you. Yeah, and absolutely agree with John's comments. Charlie?
Yeah, I was just gonna also agree with that, that one of the beauties of the single payer, it would be that they would just pay the claim, and then it's up to the government to try to get the money from the insurance company, whether it's safe or whatever else. And it keeps the hassle at the government level rather than at the provider level. And so that to me is a great benefit.
Okay, with that, any other comments, questions, feedback for Charlie before we get to the next tasks? I'm gonna check in with Jeff to see if you want to say anything.
Nope, nothing to add. Thank you for asking.
Okay, thanks, Jeff. Okay, so can we go back to that slide that has the next task? I want to just be clear what we're doing next. Could you maybe just give us a very brief, I don't know, intro to the next steps, Charlie, so that we can plan, what we're going to do next meeting?
Yeah, so I think I'm going to have a worksheet on my spreadsheet that lists like the total expenditures for the various categories, similar to what exists on that leading outline sheet, but then have columns where I try to attribute those expenditures to the sources
Okay.
of that expenditure, so that we can get a start on, well, what part of it do we need to try to preserve? What part is going to be replaced in some manner? So I guess that's the essence of it. So it still stay with the National Health Expenditure Account outline, but attributing these things to the sources of the funding. So I guess that's it.
Okay, all right. Richard?
Yeah, NHEA calls that sponsors. So the sources is that left-hand column of private insurance and Medicare and Medicaid, and then they have yet another accounting for it of who pays for those sources, and they call those sponsors. So we could possibly adopt the same nomenclature.
Okay, and do you all think this is the next logical step? Is there anything else that we need to do at the next meeting on the health expenditures? I just want to make sure we're just moving along here and that we either give you enough time for it, or then we do more on revenues next time. I just want to appropriately, accurately time this out for next meeting. Any additions to this particular focus? I guess too, well, actually, we wouldn't have known yet whether the board had any feedback on our straw proposal, so we won't be able to talk about that yet. Come to think of it. Okay. All right, well, we'll go with that. Thank you so much for your work, Charlie, and I suspect Richard too. Thank you. Okay, so we want to coalesce around the research questions. My understanding is that some of the questions asked, I think mainly by Charlie via email, were answered, but we didn't get the response in enough time to post it for the public meeting. So we're not able to discuss those those answers today. That's my understanding. I know I saw something from LFO. I don't know if, I'm kind of getting confused on what's what, but I don't know if those were the answers or if those were just additional, if that was just additional feedback from LFO from the last time. Maybe you, Katie, or Jenny
Yeah.
can clarify that.
Those were,
I will hand it over to you two, because I think probably you have a clear understanding.
as far as the deck and the answers that were provided by the Legislative Revenue Office, that was just a follow-up to questions that were asked during the committee meeting during
Okay.
Kyle's presentation.
Right.
There
Okay,
were
go
there
ahead,
were
Jenny.
additional questions that were sent in an email that Charlie summarized and sent to Morgan. I believe they were from the whole committee. That were questions directed to OHA.
That's
We
right.
received the
Okay.
responses to those questions yesterday, so we weren't able to post those, but we will have them posted and you can discuss them at the next meeting, the February 18th meeting. So we'll
Okay.
get those posted and sent out to the committee before that meeting.
Okay, and so now we need to go over the additional questions, I think mainly from Charlie, I don't know if anybody else had any, to make sure the committee, that we have consensus among committee members that these are the questions, or if there are any more too, so that we can just get the list completed. So, Charlie, do you want to go through your questions, or have you all, I don't know, did this go to everybody? No, probably not.
Nope, this just went to,
Okay.
nope, it has not. So that's where the committee can decide now if these are questions that want to be pursued.
Okay.
So we sort of already talked about a little bit of this, but
Mhm.
just as an accounting part of the question, I basically am asking if there is on the DCBS website an estimated 322 million was spent in 2017 for medical services by workers' comp. And the question is that, have they made any estimates for any other years? Now that I have actually more data, so the question is a little different because the value amount is only 34% of premiums. But what I also did not include when I was just looking at premiums is that SAFE especially distributes dividends to companies that put in if they have good claim procedures, and so it's actually a lot more than 34% of the total amount that SAFE kept, I guess. So because SAFE refunded a lot of what the companies put in most years, and so I guess that question is not quite the same as it would have been. But I guess the bigger question is, or general question is just, are there estimates of what the medical costs are for years besides 2017? And also, what is a typical loss ratio? That is, what fraction of claims goes out, what fraction of premiums goes out to claims that is not refunded to companies? But the last paragraph, I think we actually talked about today already, and probably don't need to do more with
Okay,
that.
so we take that out.
Yeah.
Are you all supportive of this kind of group of questions for DCBS? Just want to make sure we have consensus among the committee on the questions, and that you're all aware of the questions too, since we can't exactly share that by email to the whole group, so for the public meeting law reasons. So any thoughts about that? Any additions to questions for DCBS specifically? I can't remember if there were other questions you had for DCBS, Charlie. I don't know if this is the whole thing.
No, some of the questions I had earlier, I think I've found ways to get at the answers, so.
Mhm. Okay. Richard? Did you want to
Cheryl, I had a question about the LRO, and I know that it's not part of the public meeting material, so we can't go into it, but he talked about the corporate income tax and the kicker for the corporate income tax of 1.8 billion in 2023 or 2022, but I couldn't tell whether that, and it said that was, I couldn't tell what happened to that kicker? Was it paid back to the corporations? There's a comment on the bottom of the slide that suggested that went off to the general fund. Should I write that question to you all, and then you can forward it to?
Yeah, I think that's fine, and I want to clarify, were the LFO responses posted, Katie, or?
Yes, yep, they are on the committee's webpage.
Yeah, I was thinking, okay, so that is actually something we can talk about, Richard. So if you have a specific question and Katie and Jenny can jot that down, I'd certainly support that additional question. And speaking of the kicker, we still need to find out who can give us legal advice on the tax, that isn't subject to a kicker, by the way. I think Jenny was going to ask the legal advisor to the board. I'm not sure if you were able to do that, Jenny, yet.
I haven't spoken with Jake yet. I'm gonna ask Jake if it would be something that DOJ does the review on, if we should contact the AG's
Okay.
office, or if it's something that we would need independent counsel for.
Okay, thanks, Jenny. So Richard, could you just say your question, and maybe Katie or Jenny could get that down as a.
Yeah. I know that slide deck came out in the email. I've been trying to find it so I could just show the question, but it was about the corporate kicker. Was identified at some 1.8 billion. Did that money that's a kicker normally would go, if it's like the personal income tax, it goes back to the taxpayer. But I just wanted to know, we can ask them what happened to that 1.8 billion of corporate kicker. Does that go back to the corporation, or does it go into the general fund?
Okay, yeah, good question.
Yep,
Yeah.
I've captured that, so I will make
Thank
sure.
you.
Thanks,
Thank
Katie. Okay, John?
Yeah, I think it'd be interesting to talk with SAFE. It would be really interesting to talk with PEB and with OEB. I mean, at what point would PEB or OEB be willing to sit down and really look at what we've done and say, well, here's what our expenses have been. Here's what our revenues are that support us. Here is the percent of here's how we deal with workers' comp and the coordination of benefits with workers' comp, with the property insurers, etc. I think that would be so helpful. And I think PEB would do it. And PEB is predominantly self-insured, so we would get some also impression of what their administrative costs versus OEB that I believe is commercially insured. There's just incredible knowledge there. I've been on the board of PEB. They do use consultants, and the consultants would probably be a little wary of some of this, but I think that'd be really useful.
So, Jenny, is it possible for us to invite whoever that would be at PEB and OEB to a meeting, and so we can ask them to review our health expenditures and be able to ask them some questions?
I can certainly do some outreach and see if we can find someone from PEB or OEB who would be willing to come to the committee and try to identify the right people. That's definitely outreach too.
Mm-hmm. Great, thanks, Jenny. Charlie?
So I'm pretty sure that the corporate kicker goes to the general fund. I mean, I think that was a change that was made in our Constitution even, and that it's really earmarked primarily or maybe only for educational purposes within the general fund. So
in the case of an individual kicker, that goes back out to taxpayers, but if the corporations pay too much, we just keep it? Is that the idea?
Yes.
Okay, so it's not really a kicker. It doesn't kick back to anybody. It's just it's an amount.
No, it was a kicker for a long time, and then I think the Oregon voters changed the Constitution. But but I'm not positive of that. So it's probably a question still to ask LRO.
Yeah, the slide did suggest that it goes back to the general fund, and that's why I had a question about it. Thank you, Charlie.
thanks. We can still check with LRO.
Thank you.
Okay, so any other questions? Okay, well, that seems like a pretty good group of questions, and I imagine we'll come up with some more. Okay, now we're going to discuss resource needs for the Finance and Revenue Committee. And I think this is a good time to also provide an update on the RFP process. And I'm going to hand that over to Jenny first.
Hey, Cheryl.
Thank
So,
you.
excuse me. I'm sorry. So the resource discussion, I have a little bit of information for y'all and would like some feedback in terms of the RFP process. So as I think all of you know, we released an intermediate RFP, a smaller RFP for the Finance and Revenue Committee in particular. It was pulled from the larger RFP to see if we could bring on some help more quickly. That RFP had no bids. It was released over the holiday season, and so it was very strange that it didn't have any bids or any questions come back to it. So we were able to close the RFP. It had an ending date and closed on its own. So we went back to our procurement office and asked what we could do. What we are currently doing is going through a informal quote process where we can reach out to individual firms and ask them to provide a quote to us for the work that's laid out in our statement of work that was in the RFP, and review those without going through the formal RFP process and contract directly. So Katie and I have been working on that, and we are hopeful that we will have someone on board by the end of, well, at least proposals back and an idea of who we can choose by the end of the month. I will keep you updated on that. Hopefully by February 18th, the date of the next meeting, I will have an idea of how many proposals we've received. In terms of the resource needs for the Finance and Revenue Committee, the board has been asking what additional resources the committees might need. So I just wanted to go through with all of you a list of your tasks and then talk a little bit about who those tasks are assigned to and get some feedback from you on who might, who's currently identified to help support those tasks, and any recommendations or information you as a committee would like to see added to that, or resources that might be able to provide that information. And so take a second to look at it. Most of the services are identified to be coming through that Finance and Revenue consultant, through HMA, who is currently on staff, work that the committee is already doing. And then once the larger procurement that is for the entire board's work that focuses on plan design, finance and revenue, and to some extent operations goes through, identified here as UHP services consultant. They'll have some work that'll be done with the Finance and Revenue Committee, but given that there's a Finance and Revenue consultant coming on, we anticipate a lot of that work will be done by that consultant. But we'd like to hear from you if there are other types of information. I know that we've already identified some information from SAFE, from DCBS, and those are things that staff can work through. But any other outside support that you think that the committee might need? John.
Yeah, I think if we're going to be serious about having credibility when it comes to administrative costs and reducing administrative costs, we're going to need to have a very credible resource that's familiar with hospital administrative costs, and probably a different person who's familiar with physician group and medical practice administrative costs. And those folks are out there. You know, I mean, we just need to have somebody who has worked in those finance shops, really understands the guts of those, the business end of those operations, and what would be the impact of the kind of changes we're talking about when it comes to administration.
Hey, John, would that be a particular consultant type, or what would that look like?
Well, I suspect it's somebody who's working in the field now and doing consulting work, for physician groups in terms of their administrative processes, and the same for hospitals.
Mhm. Okay, so the first step would be to identify who that might be. And like you said, it might be different consultants for hospitals and physician groups. And I would add in behavioral health, which is the king of all administrative costs.
Right. So you would like to think that you could find a retired former chief financial officer of a hospital.
Okay. Mhm.
Who would be a credible resource. You'd like to think that you could find, a consultant who's helping independent practices in terms of their administrative approaches. So I mean, these are not going to be cheap resources, but I think they'll be key.
So just to be clear, John, is this something that the staff, that you would direct the staff to identify these types of consultants, or is this something that, based on our collective experience, that we suggest names, or how do we approach this?
I certainly think that making suggestions from committee, board members, et cetera, should be welcomed. But I mean, my guess is it'll take some searching out there to come up with the right folks.
Okay. Thanks, John. Richard?
To John's point, that we might need people with rather different background and rather different consulting experience. So again, I'm not an expert on state procurement, but it seems like it would make more sense to allocate a certain amount for someone to help us with hospital expenses and a certain amount to help us with physician group expenses or understanding their cost structure, as opposed to issuing an RFP for a national consulting company that themselves is going to go out and have to look. It seems like the latter way would add a lot of overhead and wouldn't allow the clarity and the selection of the person with the best expertise. But again, I don't know if that breaks state rules, but I'd rather be able to spend a certain limited set of money on 5 different consultants for very specific engagements than a larger program that seems softer and less directable. But
I suppose it has to do with dollar amount. But Jenny, I don't know off the top of your head if you'd like to answer that question or just look into it and into the parameters.
In terms of the procurement amounts.
Yeah, right. Mhm.
So there are different types of procurements for different dollar amounts, like you said, Cheryl. So I believe it's up to $25,000. It's considered a small procurement. And in those situations, you have a little bit more flexibility on looking at and selecting who you'll choose as a consultant. Over that amount, you go into an intermediate procurement, which is what we were looking at as the committee finance and revenue consultant procurement that just went through. And then at a much higher amount, I believe it's $250,000, you're looking at a large procurement. But both intermediate and the large procurements do have a lot of those rules around them in terms of going out for procurement for a certain number of days and the contracting period and the posting periods that take a little bit longer. But there is the ability with smaller procurements and with those individuals who already have contracts with the state. But it sounds like the individuals that we would be looking for here would not necessarily be those types of individuals. We'd be looking for something smaller.
Mhm.
Or people who maybe aren't normal contractors with the state. I did have a question, if that answers the procurement question. So there are some options, but I did have a question for the committee based on this topic. If there would be interest in, or if you believe it would be helpful if maybe instead of having a specific contract or looking at a contract early on, we looked at providing a panel discussion, if we could identify some of these types of individuals who maybe, like you said, were a CEO for a hospital or someone who's doing consulting currently with different practices or providers, if we could find a panel to come in and maybe have the committee have them available to answer questions and do a committee panel discussion, if you think that would be helpful, or if you think you would need a more committed sort of source that you had committed time with that could do extra analysis for you.
Yeah, the panel discussion sounds good to me, but what do others think? And I'll just call on those who have their hands raised right now. Charlie?
Let's see. Richard maybe should go first because his question is probably more related to what was just being discussed, and mine is a little bit different. So,
Okay, Richard?
Yeah, I think that the individual, the $25,000 or less, I think that's ideal for what we have, and that we as members of the finance committee can do a search and present them to the committee and get some questions answered. I mean, even at the typical consulting rates, that's still a substantial number of hours, and it's responsive, and we can bite off a small amount and see if the person is responsive and helpful, and take more. So I'm very pleased to know that there's the $25,000. I think that'll do it. I wasn't sure if the panel was to answer the same questions that we would ask of, say, a hospital expense consultant and a physician group expense. What would the panel be doing the same thing or something different? I didn't get that.
Well, I think that's up to you. But my question was, do you think, and I think Richard, you did answer it. Do you think that it would be enough, I guess, to invite some of the practitioners that you're talking about, some of the individuals doing this type of work, or who, like I think Charlie mentioned, or maybe John mentioned, are retired from this type of work, and ask them to do a panel forum to answer the questions of the committee? Alternatively, would it be necessary to have a contractor who was committed to the committee, who was doing actual work for the committee, not like a panelist who came in and gave information and answered questions, but someone who we were contracted with, who would provide data or information, or be at the disposal of the committee to take away questions and do work and answer those like a contractor?
I would prefer the latter, an individual consultant. Over.
I wonder though, if maybe starting with a panel would be a good place to kind of I don't know, further hone down our questions. It might be a good beginning discussion, and then we contract with a consultant afterwards. I don't know. It might be just a starting point.
Would the panel be paid, or would they doing it betting on that they get a later contract? I didn't understand how that would.
Yeah,
be.
that I don't know. That's a good question.
Well, in what I'm recommending or thinking of, I guess providing, not recommending, is the idea of a panel, not a paid panel, just individuals who would come and give some information. We recently in the operations committee had a panel of individuals come in and give us some background information on public corporations. Most of them were previous or current employees of an organization. So we had the government relations and counsel from SAFE. We had someone else from the Willamette Locks, which is also a public corporation, and then the former general counsel of OHSU come in and just answer some questions for the committee. And they just did that, you know, at the request of we reached out and asked them if they would come and give some information to the committee. So in my mind, it would be something more like that, not paid panelist. That would be something that I'd have to look into in terms of how we would be able to contract with and pay sort of a one-off for people to come in and provide that type of information.
Yeah, I think it's something to consider. And again, it might be a good place to start, just to see where we want to go, and potentially one of those panelists or two of those panelists are people we want to contract with. Anyway, I don't know. Okay, Charlie.
So my comment relates to probably more of a request to another committee and resources for another committee. And so maybe we can hopefully go back to that, because Chunwei may still have something to say about this, but mine is more related to talking about a request to another committee, I guess.
Well, let's just go ahead and note your request, and then we'll go to Chunwei.
Okay. Okay. So hopefully we can come back to it. Thanks.
Okay, Chunwei.
Yeah, mine is related to what we were just discussing. I like Cheryl's idea that we might consider having an unpaid panel as a starter to help us identify more detail in terms of what kind of data we are looking for before we contract a consultant. And I also want to comment that we need to get a more accurate estimate of what are the potential saving in the administrative costs from the hospital side and from the clinic and group practice side, because this will affect at least two very important our future actions. One is the more accurate predict the expenditure, and the other is down the road. We know how much saving a single payer universal health system can promote, and that will be important in negotiating the future payment rate. That because we help hospital and clinic reduce those costs that used to be on the hospital and clinic side, and so ultimately we need an accurate estimate that require consultant. But as a first step, I agree. I support Cheryl's idea to invite a few professional or expert to give us better idea of what we are looking for.
Great. That seems like a concrete next step. And if you have suggestions for who to invite on that panel, just let Jenny know, Jenny and Katie. Okay, now Charlie.
So my comment is related to what I think is going to be a really difficult task, and that is getting sufficient input and feedback and discussion about our potential revenue plan, our potential tax structure, so that there's a chance that Oregon voters might support it and feel like they have some say in it. And in my view, it's going to take a lot from the communications and outreach committee, and probably a lot of focused groups, maybe of the kind that Chunwei has promoted, looking at a citizen jury kind of thing, looking at possible tax structures that we have put out there and saying, well, is that fair enough for us to want to support? And I think that's going to be a very large task and is going to require a lot of public outreach and back and forth and citizen input. My hope is that the communications committee can maybe talk about that, and I would expect it's going to require some a fair amount of money to do a reasonable job of this, and so I think that is, to me, is a really important question for the budget, which my understanding is going to be discussed at the next board meeting, and I'm not sure the communications committee has looked into this yet, but I think it's going to be a substantial cost to do what needs to be done to have a chance of success. So just put that out there.
Yes, I agree with you. I know Chunwei recommended this concept of citizen juries, and we did talk to the current consultant who's helping with the focus groups, and this certainly isn't in the budget. So it's like, I think it's like 5 focus groups or something, and I agree with you. We're going to need way more focus groups, or as you call them, Chunwei, citizen juries, to develop these proposals so that we get them right. So totally agree. John?
Yeah, I mean, I want to put a couple of ideas in the mix because I think we're talking about, I think most of us realize we've got a math problem that is, under the current ways we're thinking about it, unsolvable. We have to think about it differently. And I think there's some ways to do that. I mean, one aspect that we need to think about it is to the degree we make any additions in Medicare benefits or changes in Medicare, there's a rationale that this could be passed across the entire population, just like right now, the entire working population pays into Medicare. And so you can imagine a payroll tax that's specific for, quote, Oregon Medicare, and is in a Oregon Medicare trust fund, because it has to be there for the 18-year-old who makes a contribution and turns 65, 45 years later. And I think that would have an interesting impact. I think we also have to look at some challenging waivers, and the waiver I think we need to consider is a waiver around normalization of payment. It's a transformative change for the fundamental rate of payment to be the same regarding which funder the money's coming from. That's a fundamental change. And I also think we're talking about a fundamental change in the administration of these programs. Those are two things that seem to me like our waiver material for Medicaid. And we'll need more Medicaid funds so that Medicaid can raise their rates. Although the amount they need to raise their rates will be modified if we're successful in reducing administrative costs. You follow me? And a portion of that, of course, would be paid by Oregon taxpayers, because Oregon has to fund Medicaid, 25, 30%. And likewise, I think it would be interesting to try and imagine an approach to Medicare which would resolve that inequity, which has been a major problem for Medicare since its start. That it's perceived by some to be an inferior payer, and so folks don't participate, or oftentimes they say they participate, but in fact, they put a number of obstacles in between Medicare patients actually getting appointments and all. So, if you could get Medicare and Medicaid to fund up to a standard rate, that's a lot of money. That is a lot of money. If you were able to, when I'm searching for the word, fund the Medicare piece over a 40-year period, to have all those age groups coming in, and you have everybody under 65 paying a small amount in, but that's accumulating, over the course of years. Anyway, I think if we realize that we've got to do something to get this math problem more solvable, and start to brainstorm about that.
So, do you think that the finance and revenue consultant, whoever that may be, can help us address that set of issues, John? Or are you, I mean, how would we resolve that? Are you talking about, you know, further committee discussions about this? Just in terms of resources, like what do we need to solve that math problem?
Well, I mean, I think the consultant could certainly do the math, you know, and because what did I think Optimus thought that you know, the current payment factor would change to 123 from 170 for commercial, 115 or something like that for Medicare, or maybe it's 100 for Medicare and 85 for Medicaid. And you know, doing the math, you could get a sense of what would shift in terms of funding. That would be a start. I think the consultant, you know, given the option of financing the Medicare Oregon piece over the entire working population via a trust fund mechanism would kind of take another piece out that I think is more easily explained to the Oregon public. And then, you know, the final piece is I think we can start to see as we look at Charlie's numbers, individuals are currently paying hundreds of millions, billions of dollars into the healthcare system on an individual basis. So then it comes down to, do you want to pay this as a tax, or do you want to keep paying it out of pocket in a very unpredictable way? With sometimes some of you are going to be, you know, I'm traveling and I'm with some friends, and one of my friends is facing this daunting task of now into second and third line drugs for the problem they have, and you know, drugs that cost $17,000 a month. And you know, they have Medicare. I think it'll be moderated by the Biden stuff, but they're unsure. And even though they're folks who have significant resources, that's a lot. So anyway, that's where I'm at. We have to look really hard to figure out how to do this differently and really
I think John froze, at least for me. I'll just say I agree that the out-of-pocket case is one of our strongest in terms of like showing side by side what you're paying now and then the new tax you would have, or increased taxes you would have. I think that is such a strong argument. So with that, I know we're getting close to time now. I thought we actually would have extra time, but this was a really good discussion with lots of great ideas. So with that, though, we're going to go on to the next steps, reflections, like we usually do. So I'm going to try to synthesize what we came up with. So we decided, so on the straw proposal, Charlie's going to offer a couple of more additions. I'm also going to work on the recommendation statement or the straw proposal statement, and we'll put it forward from there, not changing the content substantially, just based on our discussion today, that there was agreement to do that. We have next steps for the health expenditures discussion, breaking them out by payer source. We called it something else, but I'm forgetting what that is. And we are going to identify a panel to help us talk about, let's see, just a second, administrative costs, from hospitals and medical and other provider practices. We'll start there. And let's see, we've got some recommendations for other committees on resources needed. I'm happy to take that to the board or to those committee chairs. And then let's see. So I'm going to probably need some help in terms of the next meeting, which is on the 18th, from staff on the revenue topics. So we've got the health expenditure topics, but I'm hoping you can remind me what's on next for revenue. So just to give everyone a heads up on that. Jenny, are you able to go through the next steps for revenue? For the
I will
18th?
I'll pull up the agenda for the 18th.
Okay, oh, great.
Just
Just
give
to
me
give
one second.
everyone a preview really quick.
Yeah, but it'll just take 1 second.
And I think that was all. The one question I had at the beginning was whether you had questions for operations committee on waivers, if there was anything that came up for you. And if you think of something, feel free to email me if you're not thinking of it now.
Here is the draft agenda for the
Okay,
18th.
all right. So we'll be reviewing budget target assumptions from HMAs, helping us with that. Doing some health expenditure work as we discussed. Looks like we're going to do some small group discussions. I think we're fleshing out the agenda a bit this Friday, so we'll have more details and some materials too for you soon. Okay, with that, any other reflections? Did I miss anything in terms of next steps? Yeah, go ahead, Richard.
So I had two questions. Number one, Cheryl, you just mentioned something about waivers. Can you review again what you were asking about with waivers? Because
Well,
that's obviously crucial to all of this.
Yeah, it was just a general question from operations committee, whether we have any questions for them as they're beginning to address waivers. So it was just a very general question.
So on the issue of waivers, and I thought it was the general board that came up with the idea of 2030, and that one of the issues was that after the 2027 legislature reviews our report from September 2026, then at that point, the 2027 legislature would need to start the course to apply for federal waivers. So, I mean, that was my understanding, and that's why we said then, that's why we need to do this for age it out to 2030. Am I correct on that?
Well, we actually talked about it in the committee meeting, and this came up I think by Charlie. What the board said was 2026 would be too early. I think they were talking more around about 2028. But Charlie may have something to add on that. Go ahead.
But I mean,
yeah,
go ahead, Charlie.
Well, so my reasoning for why we're thinking about implementing in 2030 is that the earliest we can imagine the legislature acting on this is 2027. And they would very likely, even if they decided they wanted to pass it, it would almost surely be referred to the voters. A more likely scenario is that the legislature would just decide, here's what we're going to submit to the voters. And so my expectation is that it would be put on the 2028 ballot and probably on the general election ballot, not the primary election. And that would mean that the earliest that the voters could decide on this would be November of 2028. Well, there's almost no chance that you would go from saying, oh yeah, we passed a law in 2028, November of 2028, and now we're going to start in January of 2029. So I'm expecting that the earliest we can imagine starting is 2030. So that's my reasoning for 2030 date.
Perfect. So that said, if we're getting ready for 2030, and I think that's the right way to go, when do we start? When is the board's view that we start on waivers, applying for waivers?
You can't really
Medicare, Medicaid.
You can't really apply for waivers until you pass a law, but you can probably start negotiating with with CMS about waivers prior to passing a law. So in some respects, I would expect it depends on, it would depend upon the federal administration, I think. And so I would, again, expect that 2029 is probably the earliest you could really do serious negotiations about waivers. But that may not be what the board's thinking, but that would be what I would expect would be the case.
So with that said, what is operations, when they talk about waivers and some input from us, what, in the context of what Charlie just said, how does that apply?
Well, I think that's a good question back to them, is when
Okay.
when they're thinking of applying for waivers. I mean, what if they have a date in mind, you know, given what our assumptions are? And then Jenny has her hand raised.
Thanks, Cheryl. I can provide a little bit of information about this. So the Operations Committee will be taking up waivers for the first time in their February meeting. This will be the first time the committee has had a conversation about waivers. We will be having a background and overview presentation about waivers, what waivers the state currently has, what waivers the state would need to implement a plan such as this. And then we'll be talking about what kind of recommendation the committee would make to the board in terms of what the plan would be to apply for a waiver. But Bruce Goldberg, who's the chair of the committee, has made it very clear that in his belief, it's the conversation for the board to have in terms of what the waiver process that the board would like to see move forward, when they would apply for waivers, if they would apply for waivers, and what the plan B would be if they could not get a waiver. And so this is really a very preliminary discussion by the Operations Committee to begin the discussion about waivers. And so Bruce asked that we reach out to all board members and all committee members to say, what are your questions about waivers as the committee starts to take up this issue and starts to get some background and understanding? Where should they direct their thinking? What should they start thinking about in terms of the waiver questions? I hope that's helpful.
And you can think about it. I mean, I have time, and I can talk to Bruce we'll maybe have this discussion at the board meeting on the 20th, so we do have some time. Go ahead, Richard.
The other thing I wanted to comment about is on the revenue side. We've had several presentations from LRO on revenue. I think that the next thing is we know within 5%, thanks to Janine's work and Charlie's work, we know within 5% what the 2023 expenses are. So I would say that the next plan for this committee is from the revenue office to plan out, all right, just an income tax and a payroll tax employer paid, and say to meet 2023 expenses at 55 billion or whatever that number turned out to be, what would the tax structure look like? I mean, we need to start getting down to brass tacks, and they can go ahead. So I would say the next round from LRO is, okay, you know what the goal is, 55 billion. What would that look like in terms taxes? And when I say 55 billion, that's the total. Of course, we're getting a huge chunk. We're probably getting some 38 billion or 35 billion for Medicare and Medicaid. So we're really talking about making up that 20 billion that is right now coming from employer premiums. But anyway, have them start presenting what it would look like in terms of real taxes. How does that sound to others?
Yeah, that sounds reasonable to me. Jeff?
Yes, I agree that sounds like a reasonable approach. One other comment, one other question. The question is, will the updated material that we've gone through with the updated draft be available on the webpage?
Updated draft, what?
That we were going over earlier today.
Oh, okay. You mean the spreadsheet? That one?
Oh, I think he's talking about the straw proposal, right?
The straw proposal. Yes, definitely.
Okay. Good.
Yes.
That's number one. And then number two, in terms of communication to the full board, if they are not already cognizant of it, I think we need to emphasize no waiver, no plan.
Okay.
I mean, if we're daunted by the numbers now, by what we need to do
Right.
without the waivers, it's not going to happen.
Uh-huh.
And I think that message needs to be communicated.
Okay.
Thank you.
Yeah, sure. Okay, with that, I just want to make crystal clear, sure, that we don't have any public comment still. Is that right?
That is correct.
Okay. Thanks, Katie. All right, well, oh, go ahead, John. You get the last word for today.
I just apologize for losing my internet connection. Have no idea what happened.
Huh. Did you have anything to finish saying then, by the way, since you?
You know, the example I was giving was of the Tennessee waiver in the 90s, in which the government went way beyond anything they'd ever done in history in terms of a Medicaid waiver. Now, it just so happened that the vice president was from Tennessee and the Senate president was from Tennessee and of the other party. But, you know, transformative waivers can happen. Oregon's had some of them. And, you know, I a little bit like what Jeff said, even I think stronger. We not only need a waiver, we need a transformative waiver, and in which Medicaid would fairly step up to more responsibility here, and in return get a reduction in administrative costs and equity, and that would be an incredible experiment for a state to do.
Yes, definitely. Oh, you just reminded me, I'd still like to hear from Washington and California on how they're proceeding. And that could be like more of a board discussion, I imagine, but I mentioned that at the board. I'd still like to know what they're all doing and see if there's, you know, maybe we could even have a learning collaborative or something. See, just to learn from each other. All right, so with that, I think we've got our work before us. Our next meeting is the 18th, and again, we'll pick up revenue again. We'll still do some health expenditures stuff. And you'll see a couple of work products in between. So those are that's the straw proposal for one, and hopefully we'll be able also to identify who's on that panel on administrative costs too, among us. So just remember, if you do have ideas or further questions, please send them to the staff and not to the whole group on email. Thanks. Thank you for your participation and great discussion. And we'll see you next time on the 18th.
Bye-bye.
Adjourned. Bye-bye.
Thank you.